So today we are going to start a new chapter, that is disorders of early pregnancy, in which the first and most important topic is miscarriage. Miscarriage is defined as the spontaneous expulsion of the product of conception before the 24 weeks of gestation, and it is a spontaneous process, whereas the elective abortion, it is an induced process. And the miscarriage is divided into two main types. First one is the early miscarriages, or the first trimester miscarriage, that occur less than for 12 weeks of gestation, and the late miscarriages, which are the second trimester miscarriages, they occur in between the 12 to 24 weeks of gestation. And the risk factors for the miscarriage are chromosomal abnormalities. So chromosomal abnormalities are the most common cause of early pregnancy miscarriages, and in which the trisomies are most common. Next one is structural abnormalities like septate uterus or Esterman syndrome. They may lead to the miscarriage, and the endocrine causes like diabetes mellitus, hypothyroidism, PCOS may lead to miscarriage. And the genital tract infections, cervical incompetency, and the immunological causes like antiphospholipid antibody syndrome and SLE, they may lead to the miscarriages. And antiphospholipid syndrome can lead to recurrent miscarriages. First one is the early pregnancy miscarriages. So they are more common than the late pregnancy miscarriages, and they occur less than 12 weeks of gestation. And the pathophysiology is there is inadequate placentation occur, there is defective transformation of the spiral arteries, and there is reduced or decreased tropoblastic penetration into the decidua of the endometrium. And inadequate placentation is more common in chromosomal abnormalities. So all of these changes can lead to the early pregnancy miscarriages. Second one is the late pregnancy miscarriages. They are less common than the early pregnancy miscarriages because the rate of pregnancy loss decreases with increasing gestational age. And the pathophysiology of the late trimester miscarriages include intrauterine bleeding, which sensitizes the uterine cavity and leads to contraction. And there may be intrauterine infection occur, which ascend through the vagina and the cervix and to the fetal membrane. There may be abnormal uterine cavity that occur due to fibroids or some congenital anomalies, cervical weakness, which may be congenital or acquired, that occur due to surgery like Manchester repair or bone biopsy, and the uterine over distension that occur in multiple gestation and polyhydramnios. All of these changes can lead to the late trimester miscarriages. Next one is the classification of the miscarriages. So it is a clinical classification, and it is divided into following types. First one is threatened miscarriage. The second is inevitable miscarriage. Third one is incomplete miscarriage. Fourth one is complete miscarriage. Fifth one is mass miscarriage. And the sixth one is the septic abortion. So this classification is based on the clinical feature of the abortion and the ultrasound findings. And the vaginal bleeding is the most common sign in all of these miscarriages. First one is the threatened abortion. In threatened abortion, there is an immediate threat to abort, and the diagnostic criteria is there is vaginal bleeding occur in the early pregnancy, the cervical os is closed on vaginal examination, and pelvic ultrasound that shows intrauterine pregnancy along with a fetal heart rate, which indicate that the fetus is alive. And the supporting features of the ultrasound shows that the uterine size they correspond to the period of gestation, and there are normal HCG per that gestational age. And the investigations we do are the complete blood count, RH factor, urine analysis, cervicovaginal swab, and the pelvic ultrasound. And the management of the threatened abortion is supportive. If the pregnancy is viable, pregnancy will continue, and there is only 2% risk of spontaneous abortion. And we do repeated ultrasound to assess the interval change. And if the woman is Rh negative, we give the patient anti-D immunoglobulin. So in threatened abortion, there will be initially vaginal bleeding occur in the early pregnancy, and the cervical os is closed, and the ultrasound shows intrauterine pregnancy with a fetal heart rate, and the uterine size they correspond to the period of gestation, and the management is supportive. Second one is the inevitable miscarriage. So it is an irreversible condition that is characterized by vaginal bleeding and the uterine contractions, which lead to the cervical dilation, but there is no passage of the product of conception. And the diagnostic criteria is there is vaginal bleeding occur, and the cervical os is open on examination. The pelvic ultrasound there shows intrauterine pregnancy, but there is no fetal heart rate, which indicate that the fetus is dead. And the supportive features are there is no passage of the tissues, but the membranes are ruptured, and there is progressive cervical dilation occur. But an inevitable abortion, there will be no passage of the product of conception, and there is progressive cervical dilation occur. And the management of the inevitable abortion is initially we do medical management in which we give the patient misoprostol, which is a prostaglandin analog, either vaginally or sublingually, and the surgical options include dilatation and evacuation. Third one is the incomplete abortion. In incomplete abortion, there will be vaginal bleeding occur and uterine contractions occur, which lead to the cervical dilation, but there will be passage of some product of conception, not all the product of conception. That is why it is known as incomplete miscarriage, because there is passage of some products, not all the product of conception. And the diagnostic criteria is there will be vaginal bleeding occur in the pregnancy, and the cervical os is open on examination, and there will be product of conception at the os, and the pelvic ultrasound shows retained product of conception. And the supporting features are there will be passage of some tissues, and the membranes are rupture. And the management of incomplete abortion is supportive with observation, and the medical management include misoprostol, which is given either vaginally or sublingually, and the surgical option include dilatation and evacuation. The fourth one is the complete abortion. It is called complete because there is a passage of all the product of conception. So it is defined as the vaginal bleeding and the uterine contractions that lead to a cervical dilation with a passage of all the product of conception. And the diagnostic criteria is there is vaginal bleeding occur initially in the pregnancy, which then subsequently stops. And the cervical os is closed on examination, and the pelvic ultrasound shows empty uterus. So the management of the complete miscarriage is if initially the intrauterine pregnancy was confirmed by ultrasound, then supportive management is required. But if the intrauterine pregnancy had never been confirmed previously, then serial beta HCG titers should be performed until negative to ensure that the ectopic pregnancy should not be missed. So in complete miscarriage, there is a passage of all the product of conception, and there will be initially bleeding early, and then the bleeding stop, and the cervical os will be closed. Next is the mass miscarriage. Mass miscarriage is defined as the gestational sac which contain a dead fetus of the embryo before the 24-week of gestation without clinical symptoms of expulsion. So in mass miscarriage, there will be a dead fetus in the uterus without showing any symptoms of expulsion. And the diagnostic criteria is the patient will be asymptomatic, and there will be no history of vaginal bleeding, and the cervical os will be closed on examination, and the ultrasound shows intrauterine pregnancy with no fetal heart rate, which indicate that the fetus is dead. And the supportive features are there will be no bleeding or uterine contraction, and the beta HCG will be low past gestational age. And the investigations we do in mass miscarriage are the CBC, coagulation profile, ultrasound, CTG, urinary, blood grouping, and the beta HCG level to assess for the period of gestation. Next is the management of the mass miscarriage. So initially we do the expected management. We wait because there may be spontaneous abortion occur. But if the spontaneous abortion do not occur within the first 28 days, then the pregnancy should be terminated because there may be coagulation abnormalities occur. If the woman is Rh negative, we give anti-D immunoglobulins. Initially, we do medical management in which we give the patient misoprostol, which is a prostaglandin analog. It is either given vaginally or sublingually. It may lead to the termination of the product of conception. And last one is the surgical management, in which we do dilatation and evacuation. Complication of mass miscarriage. So the mass miscarriage may causes DIC, sepsis, hypovolumic shock, pelvic inflammatory diseases, risk increases. They may causes renal failure, deep venous thrombosis, and there may be a venous sensitization occur if the mother is Rh negative. So, if the patient of miscarriage present less than 12 week of gestation, so there we initially admit the patient, counsel her, we arrange blood group, and we induce the patient, and then follow by the evacuation. Uh, dilatation and evacuation under general anesthesia. And if the patient present more than 12 weeks of gestation, initially we admit the patient, counsel the patient, we do blood grouping. Initially, we give the patient misoprostol, which is a prostaglandin analog every 6 hourly, then give oxytocin and wait till she expel the product spontaneously. But if the half of the products are expelled and half not, then we do evacuation and curettage. Next one is the recurrent miscarriages. So recurrent miscarriages are defined as more than three consecutive pregnancy loss, and they occur in about 1% of the couples. And the risk factors for the recurrent miscarriages are advancing maternal and paternal age, obesity, chromosomal abnormalities, and antiphospholipid syndrome. Antiphospholipid syndrome is the most common cause of recurrent miscarriages. And for antiphospholipid syndrome, we give the patient aspirin and low dose heparin, which reduces the rate of miscarriages and APS by 50%. Last one is the septic abortion. Septic abortion is a complicated form of abortion that is accompanied by the intrauterine infection. And the diagnosis of septic abortion is there will be history of vaginal discharge occur, abdominal pain occur, and fever occur. And there may be tachycardia and signs of hemodynamic instability, like the patient have tachycardia, tachypnea, and hypotension. And CBC there will be leukocytosis occur. And similarly, there is cervical tenderness occur on examination, and the ultrasound there shows a retained product of conception. And the septic abortion is more common in induced abortion, but it may occur in certain cases of spontaneous abortion. The management of the septic abortion is initially when a patient present, we admit her, we pass IV line, we resuscitate the patient by giving IV fluids. We also obtain the culture and start prophylactic antibiotics. Similarly, for high grade fever, we give antibiotics, and for pelvic pain, we give analgesia. And if the patient having HB of less than 7, we also transfuse blood. We monitor the vitals of the patient, and similarly, we also record the input and output fluid. And similarly, we also check the coagulation profile, and we give the patient DVT prophylaxis. Once the patient is resuscitated and gets stable, then we ship the patient to the OT, and we do evacuation and curettage under anesthesia. And if there are signs of pelvic abscess, then we do laparotomy and abscess drainage. And if there is uterine perforation occur, then we do surgical repair of the uterus. And if all these options fails, then at the end we have the option of hysterectomy that involve the surgical removal of the uterus. And they had given a scenario about septic abortion. Let's read it. A 30 years old female who presented with a history of dilatation and curettage 3 days ago for spontaneous abortion, after which she presented with a history of vaginal discharge, which is a most common feature, and her BP is 120 by 70, which is normal, but heart rate is high and temperature is 102. And the pelvic examination shows that the os is open and there is cervical tenderness occur. And on CBC, the WBC count is 20,000, so which indicate that she has infection after dilatation and curettage. So it is a classic scenario of septic abortion. So it was all about the abortion or miscarriage and its types.